Extract 1. Questions 1 to 12.
You hear a physician talking to a patient called Mr. James Williams. For questions 1 to 12, complete the following notes with a word or short phrase. You now have 30 seconds to look at the notes.
Hello, doctor. Good morning.
Good morning. What's your problem?
Well, he's my father, and he had a septic shock. And when we consulted locally, the diagnosis revealed elevated cardiac enzyme profile. He had some workup done from cardiac standpoint, which has been negative so far.
Okay. Does he have any previous history of chest pain or shortness of breath?
No, doctor.
What is his name and age?
His name is James Williams, and he's 58 years old, doctor.
Does he have any history of hypertension or diabetes mellitus?
No, doctor.
Does he smoke or drink?
No, doctor.
May I know his past medical history?
Well, he had pulmonary fibrosis, and he is on prednisone. Oxygen-dependent cellulitis, status post-foot surgery with infection, recuperating from the same. Respiratory acidosis, septicemia, and septic shock. Presently on mechanical ventilation. No prior cardiac history. Elevated cardiac enzyme profile.
He had any surgery earlier?
Yes, he had foot surgery.
Okay. What medicines he is taking now?
Vitamin supplementation, prednisone, cyclobenzaprine, losartan 50 mg daily, nifedipine 90 mg daily, Lasix, potassium supplementation.
Is he allergic to any medicine?
Yes, he's allergic to sulfa.
Well, his physical examination reports show pulse rate of 94, blood pressure of 98/57, respiratory rate as normal, air entry bilaterally clear, rails are scattered, point of maximal impulse displaced, S1, S2 regular, systolic murmur grade 2 of 6. There are chronic skin changes, markings in the lower extremities. Pulses found palpable. His laboratory reports show echocardiogram is normal, sinus rhythm with wide complex, white blood count of 20,000, hemoglobin 10, and hematocrit 33, platelets of 163, international normalized ratio 1.36, BUN of 158, creatinine 8.7, potassium 7.3 of bicarbonate is 11, cardiac enzyme profile troponin 0.05, total creatine kinase 312, myoglobin 1423, chest x-ray no acute changes. He has pulmonary fibrosis and is on prednisone, oxygen dependent with respiratory acidosis, septicemia, septic shock secondary to cellulitis of the leg, acute renal shutdown, elevated cardiac enzyme profile without prior cardiac history, possibly due to sepsis and also acute renal failure. I am ordering an echocardiogram to assess left ventricle function to rule out any cardiac valvular involvement. He needs aggressive medical management, including dialysis. From a cardiac standpoint, conservative treatment at this juncture. His cardiac enzyme profile could be elevated secondary to sepsis and also underlying renal failure.
Extract 2. Questions 13 to 24.
For questions 1 to 12, complete the notes with a word or short phrase. You now have 30 seconds to look at the notes. You hear a gastroenterologist talking to a patient called Joseph Alvarez.
Hello, Mr. Alvarez. Your GP has sent us the letter about your problems, but why don't you tell me in your own words what's been happening?
Yes. Well, I've had blood in my urine and like this sharp kind of chest pain. I had an ECG for that, but it didn't show anything serious. But the pain was still there. So my doctor sent me for an ultrasound of my abdomen, but the result was all right. I think that's why he sent me to see you.
Yes, and you had a normal endoscopy 2 years ago. Well, how are you now?
My stomach always feels full up. It's just the same as before. It's been happening for at least 18 months now. If I'm lucky, on a good day I'll have no pain at all. But on a bad day it's pretty constant.
Does it ever wake you up at night?
I never sleep very well. I usually wake up because of poor breathing.
The pain you get during the day, is it when you're hungry or after eating?
Before I eat. After I eat, the pain usually goes away at first, but then it comes back again after about 30 minutes. It depends what I'm eating though. If it's something like oranges or lemons, they seem to be too acidic.
Ever had any problems swallowing food or liquid?
No, nothing like that. But it can feel like it's burning on the way down if I drink something hot.
I see. Anything else you can think of?
I often burp a lot after eating or drinking. That actually helps me feel better. I've never really vomited, even when I've been feeling my worst. But I can get this terrible taste in my mouth when I'm burping. It's like something very bitter, sour almost.
Have you ever coughed up any blood or noticed any blood in your stools?
No, thank goodness.
Okay. Are you on any medication?
I used to take tablets for my ulcer. They were red and yellow. Losic, that's them. I'd take one for every 20 days. They seem to work quite well as I remember. That's it though. I don't really like taking a lot of pills.
It sounds like apart from this trouble, you're quite well then.
Yes, touch wood. My wife and I eat a pretty healthy diet, I think. I never go out to pubs, but I have a glass of wine with dinner a few nights a week. I used to smoke 10 or 15 cigarettes a day, but I quit 2 months ago.
What about your family's medical history?
Well, I have 7 brothers and 2 sisters. They're all well and living in Spain. My mother died at 90 of a heart attack and my father at 77 of a stroke. Like I said, I've never really had any problems myself apart from this pain. I suppose I'm worried in case it's cancer.
Well, all of your tests have been fine, and your GP did a heart rate test, and that was all right too. I'd like to examine you and send you for some blood tests.
Part B. In this part of the test, there are 6 short extracts relating to the work of health professionals. For questions 25 to 30, choose answer A, B, or C, which you think best fits according to what you hear. Question 25. You hear a junior nurse talking to a senior nurse about a patient's potential death. Now read the question.
Would you listen to my analysis of this patient, please?
Yes, I can.
Mr. Swain was admitted with a contusion to the rib cage following a motorcycle accident in the early hours of this morning. He was rushed here from the scene in an ambulance and remained unconscious throughout. His vitals are stable with the exception of his blood pressure, which is high. According to the doctor's notes, it's equally likely that the patient will pull through this as it is that they won't make it. As such, we shouldn't be so quick to conclude that the patient is going to die. His next of kin have been contacted and his wife is on her way here as we speak. Does that sound like an accurate summary of this patient's condition based on their notes and this chart?
It does. Thank you.
Question 26. You hear two nurses talking about an alcoholic patient. Now read the question.
You won't believe what I'm dealing with here.
Uh-oh, you look stressed.
It's Rosemary Granbury. She's back again after going on yet another bender last night. Ugh, dealing with alcoholics can be really draining sometimes.
Has she been here before?
Only a dozen times. The last episode was in May when she had a liver transplant. She was on constant watch because of her dehydration, which is when we actually noticed that she needed a donor urgently. You'd think that would have been enough of a wake-up call, but no, here she is again after picking fights at bars all night.
Wow. Still, I don't think it's our place to judge. We'll have to care for her, just like we do with our other patients, and hope she can make better choices moving forward.
Question 27. You hear two senior members of staff at a hospital talking. Now read the question.
Would you check something for me?
Yes, sure. What is it? You can ask me absolutely anything you'd like to, so long as it's not for a bed on this ward, because we're jam-packed like you wouldn't believe.
Oh, I'm wondering if there's any space left for just one more patient.
You have got to be kidding! Did you not just hear what I said? Seriously, I wish I could help, but I just don't think it's possible. The last I checked, there were 11, no 12 patients still waiting to be warded. Your patient's going to have to get to the back of the queue, I'm afraid.
I was hoping you wouldn't say that. He's been waiting for 4 hours already. I doubt either him or his already annoyed mother-in-law are going to be too pleased about this news.
Question 28. You hear an obstetrician speaking to a pregnant patient. Now read the question.
Come on in, Mrs. Fernando. Please take a seat.
Thank you, Dr. Fellows.
I have your file from Dr. Reynolds, but would you be so kind as to tell me, in your own words, the reason for your visit today?
Yes, you know I'm 6 weeks pregnant, and whilst I'm thrilled at the news, I'm absolutely petrified at the thought I'll be a mum again soon. You see, my late husband, Jean, passed away recently, And I don't know if I'm ready to be a single mother. I have a bridge partner called Eric, who's offered to pitch in, but I know he's just being a gent about the whole thing. I doubt he's planned to take up any real sort of paternal obligations. I think everyone would be better off if I just accept things the way they are and start looking at adoption options.
Is that the reason you've booked the consultation today? Would you like me to help you explore that?
Yes, I think I would.
Question 29. You hear a conversation between a patient and his GP. Now read the question.
I've not seen you in a while. How can I help you today?
You mean besides the obvious?
Oh, right. Let's take a look. You know, I've not seen full-body injuries like this since my days as a trainee on the wards.
Not used to dealing with athletes, then?
Not for a while. That looks pretty swollen. You're an athlete, right? Which sport?
Soccer.
Were you playing when this happened?
Yeah, I had a game that didn't end too well. As well as losing 3-0, I managed to hurt myself too. Ordinarily, I wouldn't want to bother you, but I have a nasty feeling that my finger is broken, so I came here to get it checked out.
Let's take a look.
Question 30. You hear a conversation between two nurses. Now read the question.
Hi there, you must be Lindsay. I'm taking over from you.
All right, great to meet you. If you don't mind, I need to rush. Please don't forget that Bed 9 has quite a few care needs and it's on a schedule. He'll need to be checked before 9 a.m, 12 p.m, and 3 p.m, okay?
Got it. Any idea what the most urgent needs are?
He'll need a saline IV. I just did one for him, so this can be left until noon.
Okay. Any medication that I need to be aware of?
Yes, he's taking lisinopril BD and will need this topped up at some point in the afternoon.
Got it. He's got scans coming up too, right?
Yes, he'll need an MRI first thing, so better get ready for that.
At 9, right?
Yes.
That is the end of Part B. Now look at Part C. Part C. In this part of the test, you'll hear two different extracts. In each extract, you'll hear health professionals talking about aspects of their work. For questions 31 to 42, choose the answer A, B, or C, which fits best according to what you hear. Complete your answers as you listen. Now look at Extract 1. Extract 1, questions 31 to 36. You hear a senior nurse, called Belinda Shelton, giving a presentation about an outreach influenza vaccination project in Australia. You now have 90 seconds to read questions 31 to 36.
Good morning. My name's Belinda Shelton, and I'd like to tell you about a pilot project that my hospital here in Australia was involved in recently. This was basically an outreach influenza vaccination program. I'll give you a very brief overview of what we actually did, and then discuss some of the lessons we learned from the project. We were particularly interested in investigating high-risk groups to find out whether they were missing out on getting flu vaccinations. So, for example, you might have patients with a range of conditions who are already receiving care from multiple subspecialists. Most of these patients will already have healthcare providers because of their pre-existing conditions, but these healthcare providers may not see their primary role as one of prevention via vaccination. Because of this, we suspected that many of these high-risk patients may not be getting flu vaccinations, even though they don't have to pay for them and there are well-established services for delivery. We identified key populations on 16 sites. A mobile nurse-led immunisation service attended each site to collect data on patient comorbidities as well as to administer vaccines. A total of 520 vaccines were administered, and data was collected at the same time through interviews with the patients. The most common comorbidity reported was diabetes. Rather than reflecting a more general health trend, this probably reflects the nature of the sites visited, which included 2 diabetes clinics, as well as centres for the homeless, refugee centres, and residential facilities. One conclusion that was suggested by our project was that it would be possible to improve the delivery of vaccines by appropriate identification of vulnerable members of the community. We found that lack of knowledge, language barriers, or cultural factors mean that some people may not be aware that they can have free vaccines. And even if they know that they don't have to pay for the vaccine itself, they may be worried that going to a primary care facility to receive it might involve some other sort of payment. And in some cases, they may not even know that they're in a high-risk group and that it's especially important for them to be vaccinated. Now, on to the lessons learned. On this project, we included 3 residential care facilities for elderly people. However, we found the aged population in residential facilities already have established guidelines and infrastructure in place to receive vaccinations from their primary healthcare provider. Providing a mobile outreach influenza vaccination service to these residents could have a negative effect on this system and create a problem in the future if the outreach service was no longer available. In addition, it became apparent after the site visits that the majority of vaccinations administered and the priority at those sites were for staff vaccination rather than for residential client vaccination. Although staff vaccination is important, this wasn't the primary objective of the project. One of the most important things we found out was to do with planning the visit to each site. We found that for success on the day of the site visit, it was a good idea to advertise and explain the service beforehand. Another consideration for future years, though, is to do with the fact that peak protection from influenza occurs 3 to 4 months after vaccination. And it's important to be aware of that when deciding on the date when it's going to be administered. And it also became apparent at many of the visits that this model of delivery involving a mobile nurse-led service could be applied in other areas. Feedback from both staff and participants indicated that there was a strong interest and demand for paediatric influenza vaccination and also for other maternal vaccinations such as whooping cough. We found that at many of the refugee sites, attendance was by families, particularly women with young children. It wasn't ideal to be limited in the scope of vaccination when there was both demand and opportunity for it. Similarly, at a number of the sites, pregnant women were aware that they needed protection against conditions such as whooping cough as well as influenza. And since both of these are recommended in pregnancy, this seems the way we should be going. What the project has shown us is that taking vaccines to vulnerable populations is well received and remains an important strategy to maximise uptake. And this is true even within high-income settings with universal access to healthcare, such as Australia.
Extract 2. Questions 37 to 42.
You hear an interview with a public health researcher called Dr. Pauline Davidson discussing research on a secret safe injection facility in the United States.
Okay, my guest today is Pauline Davidson of the University of California. Dr. Davidson is here to discuss the findings of 2 studies that focused on the effect of a secret safe injection facility in the US. Dr. Davidson, thanks so much for agreeing to talk with me today. So, what was your big takeaway from your research?
One of the things people have said about opening safe injection facilities in the United States is that the US situation is fundamentally different from that of other countries where it's being used successfully. It's an argument that just because it can work in Europe or Australia or Canada doesn't mean that it'll work here. The big takeaway from this research and all the data we have so far is that these kinds of facilities have a similar effect here in the United States as they do elsewhere. They reduce harms associated with drug use, and they reduce social nuisance associated with drug use in the same way they do elsewhere. Basically, anywhere that you have a concentrated street-based drug scene involving a lot of fairly impoverished people using drugs, you get the same set of problems, and the people using drugs have the same set of problems. And these facilities deal with them quite well, whether they're in Vancouver or in Los Angeles and Skid Row, or any other area with a lot of drug use anywhere.
So, how did staff get the secret facility going?
This is an organization that was providing other services to drug users. They were in this really frustrating situation where they had a lot of people they provided services to who were dying of overdoses. After looking at safe injection rooms and how those work elsewhere in the world, they realized that if they waited for advocacy to legalize these facilities in the United States, all their people would be dead. So, after a good deal of discussion about it, they decided to implement something along these lines. Initially, they started by re-equipping their bathroom, so it was better suited to safe drug consumption. But that had too many logistical problems. They couldn't use the toilets because drug users were in there. They had a spare room available, so they refitted that. They modeled it after the Vancouver facility and opened their doors to a group of their longer-term users, and continued ever since.
What actually happens? How do they ensure safety and that kind of thing?
Well, it looks pretty much like an ordinary clinic. It's a fairly large room with 5 separate stainless steel injecting stations, and the staff are always in the same room as the clients. People come in, do a check-in on a laptop, sit at an injecting station, and prepare and then use their drugs. Then there's a couch if they want to sit there and wait for the immediate effects of the drug to wear off. The staff are trained to use naloxone and, if necessary, call 911. And since they're in the same room, they observe people injecting, and if they see some injecting practices that are less than ideal from a public health point of view, there's an opportunity to talk about that. So there's a number of benefits to having a staff member in the same room, rather than just overdose prevention.
What are users like about the facility?
Well, the biggest one that they kept talking about is how they're able to get out of the public eye, take their time, and use in a clean, well-lit space. People talked about using in the public eye and shooting up in a hurry between 2 cabs in the streets. They were very much aware of passers-by, not just because it's illegal, I mean, they're aware of the police, but because they're aware that it's not seen as a nice thing. They're particularly terrified of being seen by someone's children. So being able to get out of the public eye was very much a relief. So there's a serious benefit to their well-being, how they feel about themselves.
Did users have any complaints about the facility?
Mostly that it wasn't open 24/7. They really liked the space, and they would like it to be open far more often. A couple of them also talked about the problem of how the organization couldn't closely coordinate or do referrals to other agencies because they were trying to keep this all on the down low. Users were quite aware of this. They were saying it would be better if this organization was really closely coupled with a treatment agency, and that handoff could be much better. The staff were also quite bothered by the fact that they had to keep the facility to a fairly small number of people and felt like they had to exclude people with mental health issues because they felt like including them would be more likely to lead to disclosure to third parties. So the organization couldn't serve a number of people who were likely at a higher need.
That is the end of Part C. You now have 2 minutes to check your answer.